various causes and the various things which causes like pathophysiology and all that, in which the glucose is less, in which the glucose is more, all that will be discussed up in this particular meningitis stuff. First of all, the infection to be dealt in the CNS1 is meningitis. Meningitis, as the name suggests, is the infection of meninges. Okay, pia mater, arachnoid and dura mater, that you already know, the membranes that line up the brain and the spinal cord. The meningitis can be categorized as acute, subacute or chronic. And on which particular thing you like categorize them like this? On the speed of the initial presentation, okay, and the rate of the progression of the illness. Rate of the progression of the illness, in how much time they cause this particular infection, or on the like initial presentation, how does it present off? Okay, is it in hours together the features have come, or it is in the days, or it is in the weeks, or it is in the months? So that particular thing categorize them as what? Acute, subacute or chronic. Now, acute meningitis is mainly done by whom? The bacteria, that is the pyogenic bacteria, and in them the most important one, or in fact the most common cause of bacterial meningitis is pneumococcus. Okay, that is the pneumococcus, also known as what? Streptococcus pneumoniae, along with the meningococci. Okay, so these are the important ones which does this, and the full list we'll discuss later. Okay, and the viruses like Coxsackie virus and herpes simplex virus type 2. See this particular thing, type 2, not type 1. Type 1 leads to what? Encephalitis. Okay, and that too which involvement? Temporal lobe involvement. But this one, type 2, is associated with meningitis, and obviously it is secondary mostly to what? Genital infections, and later on it can do this meningitis features also. Okay, now the viral meningitis is often called as what? Aseptic meningitis, and the most common cause of aseptic meningitis is enteroviruses, which consist of what? That is the echo, as well as it consists of Coxsackie virus. And why it is known as aseptic? Because the routine cultures for the bacterial pathogens are negative here, and there is not much change in the profile of the CSF. Okay, when you've done the lumbar puncture and all, na, in that when you see up the CSF, it will not be having much of the changes. So that's why it is mostly termed as what? Aseptic meningitis. The subacute meningitis, that is being caused by Mycobacterium tuberculosis. They call it as subacute one because the changes, they take time. And the fungus like Cryptococcus neoformans, they also does a subacute type of meningitis. Okay, obviously secondary to the immunocompromised state, like in HIV, that is the most common cause of meningitis. What? Cryptococcus neoformans. The causative organisms are often found in the spinal fluid located in the subarachnoid space, so that you already know. Now, what is the pathophysiology? How does the infection happen? What is the mode of the spread mostly? So, as it is written properly, that hematogenous spread. Hematogenous spread happens, and that is the most common route by which the organism reach the meninges. And it can be one thing like direct spread can happen via the adjacent infections. Why neurosurgery also the spread can happen up, like somebody is going for CSF shunting, and you know CSF shunting is done for what? That is done for hydrocephalus and all. So anybody undergoing any neurosurgery, that can also leads to like this particular episode of meningitis and all. Why trauma? Suppose there is a damage to the cribriform plate and all, and there is a direct inoculation of the organism thereby after the trauma. So that can also be one of the way by which this particular infection can go to the meninges, and there is an inflammation of the meninges. Okay, but if overall somebody asks you what is the most common mode, answer is hematogenous spread happens up. It can be a bacteremia, it can be a viremia. Okay, so this is to be remembered. And like in the pneumococcus also, what happens? Like firstly the pulmonary infection happens, and then through the hematogenous route it goes to the meninges. Same in the meningo. Okay, firstly the lungs are involved up, okay, and later on it goes into the brain by the blood. Okay, so that's why you go for blood and CSF culture both there. Fine. And as we are emphasizing this hematogenous spread in our lecture, and this is how does they confirm up that this hematogenous spread do happen? Because what they have seen, that there is a success of the conjugate vaccines against certain organisms like Streptococcus pneumoniae, okay, against this meningo, okay, Haemophilus influenza type B, that induce circulating IgG antibodies, and they neutralize the bacteria in the blood. Okay, what they want to say from these lines? They want to say from these lines that this hematogenous spread is being proved in an indirect way by what? Because what they have seen, when they have given the vaccination against the pneumo, against the meningo, against the Haemophilus influenzae type B, then what they have seen, that that particular person is having what? IgG antibodies within, and those IgG antibodies, they neutralize the bacteria in the blood. Okay, so this shows, and they do not develop any meningitis and all. This shows that the main route of spread is what? Hematogenous. Because the success achieved is remarkable, and especially to this particular organism, Haemophilus influenzae type B, it is being said that the incidence of this infection have decreased like anything after the introduction of the proper vaccine. Okay, and the fight is on for these two, but for this the incidence have decreased like anything. Otherwise, it used to be number one in every particular like list, but now it is like pushed up to down, and the magic is being done by whom? By these conjugate vaccines itself. Okay, now, so basically I've just told you acute bacterial meningitis begins with the nasopharyngeal colonization, mostly in the like meningo and these all pneumo also sometimes, followed by the hematogenous spread that just now I've told you. Okay, and after that what happens? There is an inflammatory response that cause many of the clinical manifestations, especially what? Edema. Firstly inflammation happens, later on edema, resulting in increased intracranial pressure, that's obvious, and it can lead to what? Headache. Okay, so that all features you already know. Okay, headache, nausea, vomiting, projectile vomiting is present and all that stuff. Okay, and even cerebral vasculitis and infarction can also occur in the cases of acute bacterial meningitis. Okay, now this is the table from the Harrison in which they have mentioned up that how does these particular all organisms, they does various particular things in causing up the meningitis and all. Okay, so first of all, you can see up that there is an invasion of the SAS, that is a subarachnoid space, by the meningeal pathogens. Okay, there is an invasion of subarachnoid space by the meningeal pathogens, which I just talked about. Then there is a multiplication of the organisms and the lysis of the organisms by the bactericidal antibodies, if at all they are present. Okay, and naturally occurring are also there. Fine. So that is being done, multiplication of organisms and lysis of these organisms by the bactericidal antibodies, if at all they are present up. Okay, and if they are in less in numbers, then they can be handled by the natural antibodies of ours also. Then what happens after this fight? There is a release of bacterial cell wall components, and you know that this particular fight is mainly done by whom? Gram negative ones. Okay, and what they have this lipopolysaccharide. What is leading to release of which toxins? Endotoxins. So endotoxins, and for the gram positive teichoic acid and all, that is being released. And what happens after that? There is a production of the inflammatory cytokines. There is a production of what? Inflammatory cytokines by this. And what happens by production of these inflammatory cytokines? In this particular one, there is a altered blood-brain barrier permeability. Yes or no? It will happen. Then adherence of the leukocytes to the cerebral capillary endothelial cells. Okay, then there is an alteration in the cerebral blood flow, just now we have seen up, and there is a production of excitatory amino acids and reactive oxygen and nitrogen species. Okay, that will always be happening up in various inflammatory processes. So what have happened? Again I'm telling up, there is an altered blood-brain barrier permeability. There is an adherence of the leukocytes to the cerebral capillary endothelial cells. There is an alteration in the cerebral blood flow, and there is a production of excitatory amino acids and reactive oxygen and nitrogen species. Okay, these four important things they happen. Now we'll see one by one what happens by the effect of them. Okay, by this altered blood-brain barrier permeability, what happens is this mainly. That is the vasogenic edema, which you are seeing up here, vasogenic edema. And along with that, there is an increased permeability of the blood vessels with leakage of plasma proteins into the CSF. Why we always say that in various meningitis there is an increase in the plasma proteins? This is the reason, because what have started up? The leakage of the plasma proteins into the CSF, and that's why the protein content rise, okay, in all sorts of meningitis. Then what happens? The exudate in the subarachnoid space obstructs the outflow, okay, and obviously that will lead to what? That will lead to like increase in the intracranial pressure and all. Okay, so resorption of the CSF, that is also being like less because of edema and all, and this particular thing surrounds and infiltrates the cerebral vasculature. So basically, impaired reabsorption of the CSF will happen. Okay, and that will lead to what? Obstructive and communicating hydrocephalus. It can be obstructive, even communicating, and interstitial edema develops. Got my point? So basically, the permeability happens up, vasogenic edema happens up. They all, in fact, this particular chart, they all finally lands into what? Increase in the intracranial pressure. Okay, let's see the other ones. Then what happens wherever the infection, the leukocytes are there. The leukocytes, they migrate into the CSF, they degranulate, and they release what? They release the various toxic metabolites. Okay, and what happens by them? The cytotoxic edema, stroke, and seizures. Fine. Cerebral ischemia happens because of all these particular things. Fine. And there are alterations in the cerebral blood flow, which we have just seen up. It can be decreased also, it can be increased also. This particular blood flow can decrease also, or it can increase also, and they can contribute to what? They can contribute to the increased in the intracranial pressure. Okay, increase in the intracranial pressure. So remember one thing, that because of all these things, it is not always an increase in ICP. Sometimes what can happen, there is a decrease in the blood flow, or cerebral ischemia can also happen, sir, and that can land up the individual with what? Strokes and even seizures. Why the neurological deficits they happen up? This is the reason. Okay, so basically there is an alteration in the cerebral blood flow. It can decrease also, it can increase also. If it is increase, obviously it will contribute to what? Increase in the intracranial pressure. Then the last of the things is, in this particular one, there is a production of excitatory amino acids, which leads to what? Cell injury and the death. Okay, so all these things, they happen up in the pathogenesis of this particular one. Like all the steps, they happen up in the case of meningitis, that there is an alteration of the blood-brain barrier, permeability. There is an adherence of the leukocytes to the cerebral capillaries. Alteration in cerebral blood flow happens up, and there is a production of excitatory amino acids, the reactive oxygen and nitrogen species. Okay, and at the last, they all contribute to what? They all contribute to this increased in the ICP, that is the intracranial pressure, and obviously later on the coma and all, they can also happen. So basically this is the logic behind the the mechanics of developing the features in the meningitis. Why it is increase in the proteins? This itself is a question, because there is an increased permeability of the blood vessels with the leakage of the plasma proteins into the CSF. This is the reason. Okay, besides that, which type of hydrocephalus can happen? It can be due to edema, vasogenic stuff, edema, or obstructed and communicating type of hydrocephalus. Okay, and why it happens? Because these particular exudate which are formed up, they obstruct the things, they obstruct the various pathways, and that will lead to what? This obstruction and all. Okay, I suppose I made myself clear. Now, what are the various clinical manifestations which happens by this, which we have just done? So obviously there is a fever, there is a headache, stiff neck. Okay, that is termed as nuchal rigidity, which is like demonstrated by those signs, if you remember, Brudzinski and Koenig's and all. Okay, and even the photophobia, that is seen up as a clinical manifestation of all this. Okay, and if this particular meningitis episodes, they are untreated, it can progress to like projectile vomiting, seizures, focal neurological deficits, and the altered mental status. So that is obviously being told up in that particular chart, why these all things will happen, why the neurologic deficits and all will happen. Okay, cerebral ischemia happens up, there is a decrease in the blood flow sometimes, that will lead to this neurological deficits and all. Okay, and the different pathogens, they can present with rapid rates of clinical progression from acute onset and the rapid production, that you already know, that is hours to days. I've told you. Subacute to chronic, they defined as days to weeks. Okay, and this, you know, this was the question in this FMG exam, that meningo infection can be associated with what? So remember guys, here also all these features like fever, headache, stiff neck, all that is present along with vomiting, but one important feature is there, that the rash is also present in the meningococcal meningitis in most of the cases, and later on that leads to what? This thing, that is meningococcemia, and it can associates with this particular condition that is termed as what? Purpura fulminans. Okay, the photo of this is also there. So remember these particular points regarding meningococcal meningitis. It can associate with rash. Later on, this can happen up, that is the acute meningococcemia, disseminated disease, and associates with a condition termed as what? Purpura fulminans. And this was shown up in one of the questions as a picture and is being asked up that which organism you are suspecting of. Okay, so this is there regarding the purulent meningitis. This is purulent meningitis which you are seeing up here, and this is purpura fulminans which associates with this particular M. If you have to focus upon this M, and M is what? Meningo. Okay, so meningococcal meningitis associates with this acute meningococcemia which presents up in the form of this purpura fulminans also. Okay, now as far as the percentages are concerned, always a controversial thing to discuss up, but still one thing is not controversial, that this is the most common cause of pyogenic meningitis. Which one? The Streptococcus pneumoniae is the most common cause overall. Okay, then the meningo around 25%, Streptococcus epilepticus 15%, Listeria around 10%, and Haemophilus influenzae have lost the race. It have come last in this, less than 10%. Okay, this is there. In the neonates, always a controversial one, that what is the most common cause of neonatal meningitis. Now get out of the controversy and just remember that the GBS or Streptococcus epilepticus plays a role here. Okay, and these gram-negative bacteria like E. coli, even the Klebsiella, and this is a gram-positive one. This can also show up neonatal meningitis, Listeria, monocytogenes, which is a gram-positive coco bacillus. Fine. So these also associates with what? Neonatal meningitis. These four important ones. But the number one, I would say now, Streptococcus epilepticus. And the gram-negative bacteria like E. coli, Klebsiella, and even the Listeria. Listeria goes in extremes. Okay, here also and in the old age also, the Listeria can be there. Fine. Then elderly, more than 60 years. Again, the common agents are Streptococcus epilepticus, Listeria monocytogenes, and even here also I want to say that pneumococcus is number one. Okay, so pneumococcus is number one in all the age groups except the neonates. In the neonates, GBS takes the lead, along with them E. coli, Klebsiella, and even the Listeria. That is also there. Okay, but in the elderly, okay, and overall all other age groups, which is the big boss? The big boss is pneumo. That is the Streptococcus pneumoniae, which is a gram-positive cocci. Okay, now this I have already told that this is the most common one, and Streptococcus epilepticus, that is predominant in neonates, that I have discussed up. Now regarding this particular organism, Haemophilus influenzae type B, it's used to be number one, I have told you, but I have lost the race because of a wonderful vaccine of it against that type B. Okay, and that's why it is coming last in the series. Fine. And just now you have seen up that list that it can happen to cause the infection in the neonates also and in the very old patients also. Which one? Listeria. And the less common pathogens on which the question might come, that is the Borrelia burgdorferi, which is leading to what? Lyme's disease. Do you remember, guys? Borrelia burgdorferi, that is a spirochete. Okay, and somebody is sticking at your door to bring up a burger, and after eating up that burger, the patient develops what? Like the person develops what? The Lyme's disease. Means I want to say what? It is a tick-borne illness. And who is sticking up the door? A tick with a burger. And remember, like burgdorferi. Okay, so Borrelia burgdorferi leads to what? Lyme's disease. Fine. And the Rhinopneuma pallidum, the syphilis, you know that neurosyphilis features and all are there. Okay, so these all are the rare causes. They are less common pathogens, but they do ask. Now, acute viral pathogens. In the acute viral pathogens, the most common viral causes of acute meningitis are enteroviruses such as Coxsackie virus and ecovirus. This I have already told you that the enteroviruses, they take the lead, and in that also the eco and the Coxsackie virus, they take the lead in causing of what? Meningitis, and mainly their meningitis is termed as what? Aseptic meningitis. Why? Because the bacterial pathogens, they are not demonstrated. Okay. Now see this particular line. The enteroviral meningitis. It was asked in INCT exam. Enteroviral meningitis occurs primarily in the young children. First thing. and the peak incidence is in the summer seasons. Okay, the herpes simplex virus type 2 is also a common cause of meningitis here. Again, I'm telling up, focusing on the type 2, not the type 1. Type 1 associates with temporal lobe encephalitis. Another question. Fine. See here. Note that the HSV2 typically causes meningitis, where the herpes simplex type 1 causes encephalitis. This what I'm telling of. And which lobe is involved? Temporal lobe. Now, the primary genital infections with HSV2, okay, they are more likely to result in the meningitis than the recurrent SV2 infections. Okay, you got my point or not? This is a slight bit difficult here to understand. I will tell you again. What the author wants to say here is this particular thing, that those infections which are secondary to the genital one, okay, primary genital infections with HSV2, they are more likely to result in the meningitis rather than the recurrent HSV2 infection. Okay, suppose because herpes is that sort of virus which recurrent does the infections and all. Okay, and it is not mandatory to always it cause genital infections and all and then only meningitis and all. HSV2 can directly also can cause. But what this particular person is telling up here, that if it is secondary to the genital, then only mainly it results in meningitis, this HSV2, not the direct one. Okay, mostly direct one does not involve, and if at all it does, so neurovirulence will be more. Okay, so that is also there. So this line, I suppose now it's clear now that more likely the infections which happens, these meningitis and all, they are secondary to the genital ones. Okay, now, so that was regarding the HSV, herpes simplex virus. Another herpes virus also associates with the meningitis, and this can be asked in one form of another integrated manner and all. That is a varicella zoster one. Okay, that can associate with the meningitis. Although the arboviruses, they typically cause the encephalitis. We say them encephalitis, Japanese encephalitis and all that stuff. Okay, that is Eastern equine encephalitis, Western equine encephalitis, that is there. But the arboviruses like West Nile virus or St. Louis encephalitis virus, they can also cause meningitis. Okay, so another important point, like West Nile viruses and the St. Louis encephalitis virus, they can also cause what? This meningitis. Mainly they cause what? Encephalitis and all, but yes, they can irritate the meninges, they can inflame them, and they can lead to this meningitis and all. Another paramyxoviridis family member, mumps virus, that used to be a common cause of meningitis before, but because of its wonderful vaccine, now the incidence have come down. Okay, so this also needs to be focused upon. And what is the strain used for the mumps vaccine? Zarelin. Okay, so that you also know. Fine. So we have talked about the acute ones. Now for the subacute and the chronic ones. Subacute and chronic, the most common cause of subacute and the chronic meningitis, that is the Mycobacterium tuberculosis, which you have discussed before also, and the fungus such as Cryptococcus, coccidioides, you know that dimorphic one, and the histoplasma, they can associate with this particular variety of subacute and chronic meningitis. Cryptococcal meningitis, I have already told you, happens to be immunocompromised ones. In whom? In HIV positive ones. Okay. Now coming to the important aspects, that what are the normal CSF findings. First of all, we should know this, then only we can say that in which what is increased and what is decreased and all that stuff. The CSF pressure is 50 to 150 mm of water. This is the normal one. Remember guys, this is water. Then the total leukocyte count per mm of cube, it can be 0 to 5. Okay, hardly 0 or like maximum 5. Predominant cell type mostly is what? Lymphocytes. Okay. Glucose 40 to 70 milligram percent, and total proteins 15 to 45 milligram percent. Okay. So this is actually the 3 multiple of it, 15 to 45. And after that you can remember up 40 to 70 is for glucose. Okay. So firstly the total proteins P. So if you go in the Hindi and all na, P means 15. So 15 to 45 here. And after that is glucose, that is 40 to 70. Okay. So these are the normal CSF findings. And the CSF pressure is also in the multiple of 3, 50 to 150. This is also in multiple of 3, 15 to 45. Okay, and predominant cell type is what? Lymphocytes. When this is clear, then you will understand up in what is increased. Okay, now coming to this particular chart of the Harrison, in which the CSF analysis in the pyogenic meningitis is being given up. A wonderful chart. A lot of charts are there in this Harrison, and they are very good. Okay, you should see them. So let's have a look first regarding this pyogenic meningitis table. The opening pressure is more than 180. Okay, agree, because what was the normal? 50 to 150. So it is more than 180 mm of water. Then we have told that the white blood cells, there was the lymphocytes 0 to 5 hardly, and see the numbers 10 to 10,000. Okay, some says 100 to 10,000 also, but the number is huge, that is there. And see the organism, like see the cells which are predominant here. Answer is neutrophils, not the lymphocytes, first thing. Okay, then the red blood cells, obviously if you are a trained one, so you will not be having any RBCs, and if you are untrained or a fresh internee and told to do the lumbar puncture, a lot of RBCs will be seen up, because you will do a traumatic tap for sure in the starting. And don't be ashamed of it, everybody does it. Okay, glucose. The glucose is less than 40 mg per dl. Okay, I've told you 40 to 70. So that is 40 milligram per dl less than that, because the bacteria, they love glucose. Okay, then this ratio that turns out to be CSF or serum glucose less than 0.4. Protein, I've told you 15 to 45. So more than 45 comes out to be 0.45 gram per liter, or you remember in one, otherwise you will confuse up. So you remember in milligram per dl. So less than 40 here. And proteins, why they are increasing up, guys? I've told you in that particular chart. Okay, so there is a leakage of the plasma proteins. That's why it is being increasing off. Okay, now the gram stain, as per our microbiology, so it is not so that in every gram stain you will get something, but still gram stain is an important tool to diagnose up, and it is positive in more than 60%. Regarding the culture, positive in 80% of the cases. Okay, not 100% again, but positive in 80% of cases. Why it is not 100%? Because we all have doing up poor practices, or in fact that is the need of the hour, to give up the empirical treatment sometimes, and that's why it turns out to be negative in some cases, but otherwise positive in more than 80%. Okay, regarding the PCR, it detects the bacterial DNA of the specific ones. Okay, and as you know, in the COVID also, it is an important tool to measure of the things, and here also it is important. Okay, so it detects the bacterial DNA, it's very good. Latex agglutination tests are available for the various tests, like for the Streptococcus pneumoniae it is available, for the meningo it is available, and even for the Haemophilus type B it is available. So three main important ones it is available. And now recently for the E. coli and group B strepto also, they have made this latex agglutination test. Now the question have come that what is the principle of these latex agglutination test? So remember guys, the principle is immunochromatography. Okay, that is a movement it should happen up on that particular paper. Which paper? Nitrocellulose paper. It was a question in the All India. Okay, and this particular test is also, you can remember up, if which are there the gram negative organisms like E. coli, Klebsiella, then you can do this lumulase lysate assay also, because it detects of the endotoxin activity and all, and that is positive in whom? Gram negative. Okay, so this particular table is giving our full gold mine of the questions, and these are the various changes which happens in the pyogenic meningitis. Okay, means the glucose goes less than 40, the proteins goes more than 45. Okay, the numbers of WBC goes 10 or 100 to 10,000. Okay, and which fellows predominate? Otherwise lymphocytes were there, here is neutrophils, and see the opening pressure more than 180. Okay, so that is there regarding the pyogenic meningitis. And let's see up now in a tabular form the all comparison. Okay, so this is the comparison of the various organisms which you are seeing up in this particular one. Fine. So firstly, the big boss is what? Streptococcus pneumoniae. Then you have the Streptococcus aegylectia, and then this is meningo, and then this is Haemophilus influenzae. Okay, now guys, I will ask you and you try to answer up while seeing up this particular video only. Which is the most common cause here of the meningitis? The answer is Streptococcus pneumoniae. That is the most common cause in mostly age groups except the neonates. In the neonates, what? In the neonates, Streptococcus epilepticus. Okay. Then meningo also forms up as a second line and all. So that is also there. Meningococci as a prevalent one which cause the meningitis and all that stuff. Haemophilus influenzae used to be very like number one and all, high in incidence, but because of the good vaccines and all, now it is not so. Okay. Along with that, this E. coli, which is a gram-negative ones, this also leads to what? Pyogenic meningitis. All those features of pyogenic meningitis we already done. There is a CSF pressure more than 180. The leukocyte count also increase up 10 to 100 to 10,000. Glucose decrease less than 40, less than or more than 45. The proteins are there. So focus upon these particular things. I suppose the life have become easy now. Okay. If the question comes regarding meningitis, you will have ample things to write off. Okay. By this particular discussion up till now only you will able to write up. The CSF pressure more than 180. The leukocyte count is raised up. Which leukocytes? Neutrophils. Okay. Now let's see up them one by one. I know some of them are missing listeria and all. They might be further. Okay. We'll go, come to them also. Now the Streptococcus pneumoniae. What you will see in the gram stain, guys, or in the direct demonstration. Suppose you have prepared the direct one. So you will see in the gram stain gram positive cocaine pairs. That is termed as diplococci arrangement. Okay. Lanceolate shape, flame shape. That is the characteristic of whom? Streptococcus pneumoniae. Okay. Then what about the culture identification of them? So this word is important. The Drotsman shaped colony. And what does Drotsman means? Carom coin. Carom coin appearance that is observed up on the blood agar, even on the chocolate agar. Okay. Now, this everybody knows who have done my lecture and who have studied before that this is found to be what? Biopositive. And what is bio? It is bile soluble, it is inulin fermenter, and it is optogen sensitive. This biopositivity is typical of whom? That is typical of pneumococcus. So this everybody knows. Fine. So this is biopositive. Now coming to the Streptococcus epilepticus. Okay, these are the features with all the pyogenic meningitis. What is typical of it? The typical of it, you know that it's a group B strepto, okay, which is a beta hemolytic. What is beta hemolytic? In which complete zone of hemolysis is there on the blood agar. Then pinpoint colony. Pinhead colony is seen in staph. Pinpoint colony is seen in strepto. Okay, so that is observed on the blood agar. CAMP test is positive. What is CAMP test? Christie-Atkins-Munch-Peterson. This particular test is positive and it is resistant to the bacitracin. And this antibiotic testing is done on which particular media, guys? This antibiotic testing is done on blood agar. Okay, this is different because, or what you will do, you will add the blood to the MHA. This is different. This is not the normal antibiotic testing. So bacitracin resistant it is. CAMP test positive it is. Okay, enhancement to the zone of hemolysis, and the beta hemolytic pinpoint colonies are observed in the blood agar. In the case of whom I am talking about, Streptococcus epilepticus. Is it fine, guys? Now coming to the third one. The third one is Neisseria meningitis. That is the meningococci. You know that this particular organism is gram-negative cocci. Okay, gram-negative cocci. Which shape? Lens shape. Okay. Mostly resides where? Extra intra both. Okay. Ferments which particular sugar? Guys, remember it ferments glucose and maltose both. Okay. Glucose and maltose, both the sugars are fermented by this meningo. Okay. It is found to be oxidase positive. Oxidase means what? Tetramethyl paraphenylene diamine dihydrochloride. This oxidase reagent test is being done here, and the color change from white to blue within 10 seconds. And this is found to be what? Oxidase positive. Along with that, it is also catalase positive, and this particular question is already being asked. That catalase positive, oxidase positive, and obviously it grows where? On the chocolate agar. What is the name of that media? Thea-Martin. Can it grow on MHA? Yes, it can grow on MHA also. Okay, guys. So this also needs to be focused upon. Now, after that, coming to the Haemophilus influenzae. Okay, Haemophilus influenzae, and the question was there in the recent INCT exam only, that this is a pleomorphic, it changes shape, and it's a gram negative bacilli. Okay, it's pleomorphic, it's a gram negative bacilli. And what is the identification point of it? That is the satellitism happens up on the blood agar with the staph aureus streak. That I already discussed up in the bacteriology. That satellitism happens up means that it looks like the satellites around the staph aureus streaks. Okay, they increase in size and number. Okay, and the growth surrounding the disc containing the combined X and V factors. Okay, hemin and NAD, that you already know. Okay, regarding the Haemophilus influenzae, and this is important to remember that this is pleomorphic, changes shape. Fine. Regarding the E. coli, if somebody asks you, then that particular one identified on the gram stain. Okay, or by the colony growth on the McConkey agar. Why? Because this is a lactose fermenter. This is what? This is a lactose fermenter. Okay, and it gives certain biochemical reactions positive. Which one? You know that we do these tests IMVIC. So this is found to be plus, plus, minus, minus. Means it is indole positive, it is methyl red positive, it is Voges-Proskauer negative, and it is citrate negative. Okay, so the second year fellows, if you have done this much, or in the INCT, if you focus upon this table only just for now, you will able to answer a lot of questions. Okay, so this is what I want to do up with these particular sessions. Okay, so this is regarding the various ones, and the next list is this one. Okay, so next list is also very important because it is talking about the other ones, like which are causing up subacute and chronic ones, like Cryptococcus neoformans. The Cryptococcus neoformans, you know, it's a true yeast. Fine, it's a true yeast, and the CSF pressure in these particular things, they are slightly elevated, not very much, slightly elevated it is, or sometimes it can be normal also. Okay, the leukocyte count is slightly elevated, and mainly it is what? Lymphocytic. Okay, and the glucose they don't love, so glucose remains normal, and the total proteins normal or slightly elevated. Normal or slightly elevated means in the fungus the profile of the CSF does not change much. Okay, hardly it is slightly elevated, and all the things they are towards the normal side. As you know, the lymphocytes are normal, it is there, slightly elevated, glucose is normal, and the total proteins is also normal. So everything is under control. In the case of crypto, they don't like sugars, so that's why the glucose remains normal. But the pyogenic ones, they love that. Okay, so what about the investigation part? Investigation part is Indian ink stain shows budding yeast cells. What is shown up? Budding yeast cells, that you already know that it is a true yeast. So budding yeast cells will be observed up in the Indian ink stain, and this was the question in the FMG exam this time, that Indian ink staining is done. Which type of stain it is, guys? Negative stain. Okay, with a refractile capsule. Fine, obviously capsule will be seen up, negative staining it is, and this can be done for the pneumo also. Okay, Indian ink can be done for the pneumo also. This point to be remembered. The latex agglutination test detecting the capsular antigen in the CSF. Okay, that Harrison chart, if you observe up now, we have seen up that various bacterias you're having this latex agglutination test, and this is also available for the Cryptococcus. Okay, and this was asked in one of the exams. Now, if we go for the colony stuff here, that you can grow the Cryptococcus on the blood agar, even on the chocolate agar, but the favorite media is what? SDA. And which type of colonies they come? Mucoid and the white colonies. Mucoid and the white colonies they come of the Cryptococcus neoformans on the SDA. Okay, creamy, tasty, pasty colonies they are observed up of this particular one, that is the Crypto also and the Candida also. So you can't differentiate between them on the basis of the colonies on the SDA. Okay, now talking about the viral meningitis. And in the viral meningitis also, which is also termed as aseptic meningitis, this particular profile is not changed much. Okay, and there is a detection of the viral nucleic acid, DNA or RNA in CSF by PCR or real-time PCR. Okay, real time means within a particular time the results will come. So viral meningitis also will have the same features like this, and there will be detection of the viral nucleic acid by the PCR. You are seeing up that for the COVID, the investigation of choice is RT-PCR for this particular coronavirus, SARS coronavirus 2, and as such, in the viral one, RT-PCR definitely have a very good role to play. And here also the same thing, that it can be detected by the real-time PCR or by a simple PCR also you can detect it up. Tubercular meningitis. Another important entity as per the India is concerned is tubercular meningitis associated with subacute and subacute type. Okay, the CSF pressure is moderately elevated, not very highly elevated like in the pyogenic, but moderately elevated. It is elevated. The cobweb coagulum, this is observed up, okay, because of the fibrin content. It looks like a cobweb, okay, and this used to be before the main feature to make the diagnosis of tubercular meningitis, but nowadays you have PCR and all that stuff, so now it is like lessly emphasized, but still they can ask you. The cobweb coagulum is observed in tubercular stuff. Okay, the leukocyte count, again it is moderately elevated. So basically you have to remember that this tubercular one is a moderate fellow, so everything is moderately elevated. Moderately elevated CSF pressure, leukocyte count is moderately elevated, and see what is increasing up mostly, the normal counts only. The lymphocytes, lymphocytic ones, they are increasing off. The glucose is slightly decreased, okay, because they don't love so much as the other bacteria, but they do slightly decreased. And the total proteins, they are moderate to markedly increased. The total proteins are moderate to markedly increased in the case of tubercular meningitis. Okay, so proteins are mostly elevated in all, like in the tubercular also, in the fungal also, in the viral also, in the pyogenic also, all of them. But glucose, you see, it is slightly decreased here, whereas here the glucose remains normal in the fungal as well as viral, whereas it decreased to a below level, less than 40 milligram per dl in the case of these pyogenic ones. Okay, now how to go for the diagnosis and all. The Zn stain of the CSF showing up the acid-fast bacilli, the best thing to do. Okay, Zine-Linsen staining or acid-fast staining. This is acid-fast. How much acid-fast? 20% acid-fast. And you can detect the specific genes in the CSF by the PCR, or nowadays you can go for the gene expert also. Okay, and along with that you can find out the rifampicin resistance also. Gene expert rif is available. Okay, and this is PCR based only, and replacing up most of the stuffs now. Now, as per the conventional method, the culture one, culture is done on what? Lowenstein-Jensen media. Okay, and which type of colonies they come, guys, on that? Rough, tough, and buff. What is the meaning of this? They look like rough ones, rough surface. Tough means they're difficult to remove, and buff means yellowish brown color. So rough, tough, and buff, that is the type of colonies which are observed on the Lowenstein-Jensen. In how much time? 6 to 8 weeks. They take a very long time. Rough, tough, and buff. And you can find the growth in the MGIT also, that is a Mycobacterium growth indicator tube, that MGI method. And this MGIT method can be used for the detection of the drug resistance also. This also might be coming up in the exam. Okay, and other than that you have number of others for the latent TB and all. That is, you're going for tuberculin test. Okay, you're going for those particular tests, they are not done routinely. That is the TB Gold assay, all those particular things, they are the quantiferon TB Gold assay. So they are all done for the what? Latent TB and all. But as such, for the drug resistance and for the culture, you can take up what? MGIT. Okay, so this is the list which will describe up all the organisms at one place of the meningitis. And in the exam of your second prof, or for your INCT, or for your NEET PG, or for your FMG, if you just see up this table also from my video, you will able to recapture up all the organism at one go with all the features. This is the beauty of this particular table and all. Okay, so remember this is important, that just have a look on this particular, just mark it off, tagline, number, time. Okay, and just after, before going up into the exam and all, just have a look over this particular table. All things will refresh upon. Okay, so this is important. This table is very, very important. And before going off, because meningitis is a favorite question of examiner second year, and this time also in INCT the exam, 2 questions were there. In the FMG exam also the questions were there from this, and so So this is full of questions. This is gold mine of questions, and this particular table only will answer up most of yours. Okay. And the viral one which recently have come is regarding the Entero only. And just now I have told you Entero and Coxsackie, they are there which causes viral meningitis and all. And these are the features. So what else that particular one can ask in the next exam? This integration or this particular profile, these organisms and these particular growths, what is there left in this particular one? Everything is being covered off. Okay. So this is the approach to be followed up. Now after this particular table, will come up to some other relevant points, like although the CSF analysis which we have done just now is a very important step in the diagnosis of many CNS infections. As you are seeing up, you can do the gram stain, you can do the study of the CSF. Okay, so all the labs, they can contribute up by telling of the cells, which now, like how much is the amount of cells present. So all that particular details can be made by the CSF analysis. But there is a no also for the lumbar puncture. And what is that no? The lumbar puncture should be avoided if there are signs of what? Increased ICP, like already. What is that? Such as papilledema or focal neurologic signs. Okay, if you are observing up these particular signs, then you should avoid up the lumbar puncture. Okay, because what can happen in these particular cases, if papilledema and the focal neurological signs you are observing up, the herniation of the brainstem can happen and death may occur in this particular entity. Then it is advisable to go for a CT scan prior to the lumbar puncture to determine whether a mass lesion such as a brain abscess or cancer, any particular like brain tumor, is present or not. If a mass lesion is seen, a lumbar puncture should not be performed. Okay, so you have seen two things. If there is an increased pressure, that is papilledema, or focal neurological signs, you should avoid lumbar puncture. Or if there is a mass lesion, and that can be what? Abscess or a tumor, then you should avoid the lumbar puncture. So these are the like no's of not doing up the lumbar puncture. You should not do in these particular situations. Now regarding the treatment part, you already know that it's an emergency, so you have to go for what? Empirical therapy, and you have to include up those particular drugs which have excellent penetration into the CSF, and they are bactericidal. So of them, you know that ceftriaxone or cefotaxime plus vancomycin might be forming a ideal combination. Okay, this is the regimen which is followed up mainly. And this ampicillin and all is added if you are observing or if you are thinking that the age group might have the infection of what? Listeria also, or if you get a hint or a growth of this, then you have to add up what? Ampicillin, because ampicillin is the drug of choice for what? Listeria. So in this empirical therapy of ceftriaxone plus vancomycin, you can add upon ampicillin if you suspect of what? The listeria component also. Fine. Now the empiric therapy for the neonatal bacterial meningitis, that also includes the ampicillin, because this also includes with neonatal meningitis this listeria, plus ceftriaxone or cefotaxime that can be used. Acyclovir, that is used for this herpes simplex virus and varicella zoster infection also. Okay, the meningeal component. Now regarding the prevention, it's important to prevent up these types of meningitis episodes, and what is the best bet? That is the immunization. Okay, so immunization, that can be pre-exposure as well as post-exposure. Pre-exposure for those like children and all, so don't develop these all particular things, that is the vaccines and all. And the post-exposure chemoprophylaxis can also be done, like suppose a meningococcal meningitis sort of an epidemic have come, then to prevent up all other normal population, you have to go for what? A post-exposure chemoprophylaxis. Fine. Several vaccines are effective in preventing up the bacterial meningitis that we already have done, like against pneumo, against meningo, against Haemophilus influenzae. Okay, and out of them, if somebody says which is the best vaccine, is regarding that, and that have decreased the incidence of this particular organism. Okay, and the common thing in all of them is the immunogen in all these vaccines is the capsular polysaccharide of the organism. What it is? It is a capsular polysaccharide of the organism, which is the main immunogen in all of them. Okay, now The current pneumococcal vaccine, which is from the PSM also, Prevnar 13, protects against the 13 most common serotypes. Okay. Regarding the meningo, you remember the name Menectra, which is against the ACYW135. Which one is missing up? B, against which no good vaccine is available, but vaccine is there. And this is the best one, which protects against the Haemophilus influenzae. Okay, that you already know. Fine. Besides that, the pre-exposure chemoprophylaxis, that is also being done in some of the cases, like in the Streptococcus epilepticus, which leads to neonatal meningitis. So you can give to a pregnant female like penicillin and all to reduce the vaginal carriage in the mother, so that she does not pass it to the newborn. Okay, if vaginal or rectal cultures, they are positive at this particular weeks of gestation, then ampicillin should be given in these particular ones. Okay, penicillin or ampicillin, that should be given up at this particular time. So it will definitely help up to reduce the incidence of developing what? Neonatal meningitis. Right? Another prevention strategy I've just told you in the post-exposure one is aimed at reducing the nasopharyngeal carriage of meningo as well as Haemophilus influenzae type B. It is being said that the close contacts of patients with meningitis caused by these organisms which we have talked about, meningo and Haemophilus influenzae, they should receive either the ciprofloxacin, because it is orally given and can be given to a whole number of contacts which are coming up in that case contact, and rifampin also can be given for the meningo, and even it is being said that for the Haemophilus also you can give up this rifampin as a chemoprophylaxis. So these all points you need to observe up and need to focus upon, that the pre-exposure chemoprophylaxis, post-exposure chemoprophylaxis and pre-exposure vaccination obviously is done in whom? That is done in children. And this pre-exposure stuff I have discussed, it is done for whom? Streptococcus epilepticus also, that is the chemoprophylaxis. Vaccination also is one of the sort to avoid of this